Yeah, we're seeing you.
Okay, I hope everyone can hear me.
Yeah, we're seeing you and we're hearing you. Thanks, Ed.
Okay, brilliant. So just to follow on from Rachel, again, I'm one of the clinical fellows who works at Guy's and St Thomas's Hospital. I've been helping to support a new service that we rolled out beginning of last year, which is for patients with obstructive hypertrophic cardiomyopathy. So just to define the problem very quickly, hypertrophic cardiomyopathy or thickened heart muscle disease is a common inherited cardiac condition affecting around 1 in 500 people. Obstructive HCM is a kind of a subclassification of hypertrophic cardiomyopathy where they have the presence of left ventricular outflow tract obstruction. So this is a blockage or a obstruction to the blood as it exits the heart, and usually arises as a result of kind of a combination of hemodynamic and anatomical features. And that the presence of obstruction is associated with worsening symptoms and an increased risk of mortality. Traditionally, treatment for this kind of condition was used kind of non-selective pharmacological agents, things like beta blockers, which were found incidentally to be helpful in this kind of condition, or with invasive strategies, septal reductive therapies, including open heart surgery or alcohol septal ablations. So at the end of 2023, cardiac myosin inhibitors, namely Mavacamten, was regulated or approved for regulation in the UK, and we started using this in January of 2024. It's a very effective medication in terms of for symptom control, reduces their left ventricular outflow tract obstruction, and we know it increases their exercise tolerance. But it comes with significant challenges from a pathway or a service point of view. And we know that's because of complications around left ventricular outflow tract obstruction. There's a requirement for pharmacogenetic testing, with which wasn't really established. And there's significant risk for things like drug-drug interactions or fetal toxicity, and a degree of patient education is required. For these kind of patients, we know that the follow-up period is relatively intense. It's quite different to those PFIB pathway patients. These patients, on average, get seen 8 times in a year during the first year of treatment. So it can be quite an invested group that you need to be able to communicate with effectively. So the challenges that we came across, they require this frequent clinical review together with echocardiography. The follow-up period for these patients is variable. It can be anywhere from 4 weeks now up to 6 months. So there needs to be some flexibility and resilience in the pathway that you design. They need to have effective pre-treatment counselling and involvement of kind of a service to be able to give them things like the SIP testing, which is the pharmacogenetic testing, as well as genetic testing, or offer a patient education before they start treatment. And then there's the regulation part of it. It's a high-cost drug which goes through several applications in order to be able to deliver to the patient. And then lastly, we needed to have some sort of pathway in terms of patients be able to troubleshoot and for safety reporting when they have symptoms, and a way to assess them in a fast or effective manner. So again, this is quite an involved slide of the pathway, and essentially the journey starts where they have symptomatic left ventricular outflow tract obstruction with HCM, and they go through our local NDT, where all treatment options are discussed. If they're deemed to be for Mavacamten, which is this new treatment, they then get entered into this new pathway. And this pathway is kind of heavily reliant on MDT working. As we know, it needs to be robust, but also flexible. And it's kind of evolved over time as guidance or pathways have changed. We developed a one-stop kind of service with a clinical scientist-led visit, where they come in for a single point of contact and have their assessment, including kind of clinical assessment echography in one visit. We involve their CNS or their clinical nurse specialists early in terms of their pre-treatment counselling, but also to give them support throughout the process. And it's got a heavy reliance on integrated pharmacist support, so they need to be able to help us with applications. The dosing regimen is incredibly complex. I think it's a 56-page document when it first came out, and navigating that can be complicated for patient plus or clinician as well. And lastly, more importantly for this talk, is Ortus is our remote monitoring service, and it's integral to the way that we manage these patients and offer them kind of the opportunity to discuss with us if there's problems. So when do we initiate Ortus? Well, it's part of the enrollment processes at pre-screening. So before they even have the medication, they're introduced to the pathway. That includes things like education, so they can read about all the drug literature that may be available, as well as more generally about their condition. And they're introduced to the service at that point. When they come back for their visits, they're offered a patient-reported outcome measure questionnaire, so looking at their symptoms to understand if they're responding or if there's a problem which you may be able to address. And the thing that Ortus has been really helpful with is it gives us this very structured approach to be able to give them symptom assessment scores. So you can design pathways within the system to be able to send those questions out at regular set intervals, as well as kind of ad hoc. It provides that patient information for them to be able to read or educate themselves about what is quite a complex or perhaps anxiety-producing kind of new medication, and then gives them an opportunity to report any symptoms. And importantly, that allows us to act on those things. So there's still the traditional pathways for them to report those kind of symptoms, either through their CNS or whether that be speaking to A&E or their clinicians. But otherwise, this allows them to highlight where there may be problems and for us to proactively manage those problems before they become an issue. So we can arrange for either more frequent follow-up, we can give them telephone appointments, all those kind of things to react to the symptoms as they develop. And then lastly, we can do that through Ortus itself with kind of clinician-initiated messaging. So we can ask them, a few simple questions to understand whether we need to change what's happening, or if there's any acute issues with things like medication supply, for example. And this is something that we do on a pretty regular basis. Obviously, it's not a 24/7 monitored service at the moment, but it offers them an avenue for those kind of less acute problems for us to be able to deal with. Those PROM outcomes we collect on a regular basis and gives us a good view of how things have developed over time. And that kind of picture at the bottom is a single patient's journey with their medication over time, how their symptoms have changed. And in terms of outcomes from that, we've been able to collect all those PROM data and demonstrate in the real world whether the outcomes that are expected with this medication reflect those which are seen in trial data. And we presented this data at the ACC 25, so earlier this year in America. And again, we found that using this kind of platform, we can measure things like their outcome measures, which are reportable, and we can see that or track that they are the same as their trial data. Okay.